Thank you so much for having me here. I'm delighted any chance that I get to talk about this topic. And so I encourage you to ask questions. I'll go through the slides, and if you do have a pressing question, feel free to stop me. And with such a small group, we can make it very interactive. So the intersection of disability and medical education, what I was asked to speak about today are the best practices in medical education right now with regards to working with students with disabilities in all kinds of settings, whether that be in the didactic classroom, in a clinic, or in the hospital. So we'll cover some of that, and I'll give you some advice along the way about how we can welcome and make more inclusive our environment. So the first thing I want to talk about is that individuals with disabilities are, in fact, the largest group of minorities in the country. And they are the only group, only minority group, that you can join at any time. So I always invite faculty to change their perspective about disability by thinking about longevity and aging and what happens when our eyesight starts to go and what happens when our hearing starts to go, and think about your education and your contribution to medical education and how that could potentially be met with some type of barrier down the road, and how delightful it would be if you were able to still maintain access to the scope of your practice through some type of accommodation. And so as I walk you through these slides, please keep that in mind, that this is something that can happen to anyone at any time. We hope that it doesn't, but in the case that it does. So I also want to preface our talk today by just making you aware and bringing an awareness to the room about the increase in OCR complaints. And for those of you that are not familiar with OCR, that stands for the Office of Civil Rights. And that is what the ADA is. That's the enforcing agency for the ADA. What we see now are students who are more educated about their rights. We see advances in diagnostics and practice, and so students are coming to us having been identified early and being used to having accommodations in the educational setting, postgraduate as well. So these are, highly educated students who know their rights, know the law, and come to us in many cases with a history of disability and a history with accommodation. So we need to respect that and respect the process that they've been through before and understand the process so that it better informs how we work with those students in this setting. So what is the role, and I'm going to refer to this as SDS simply because it's what we use at our office, but these offices are often known under several different titles. It could be the Disability Services Office, it could be the Access Office. At Stanford and Harvard, it's the Office of Accessible Education. So really it just depends on what the language is that you use, but note that I'll use SDS because that's what my office is titled. So my role and SDS's role is multifaceted. We're experts in the ADA as amended and all the applicable laws, and I keep note of case decision-making, OCR complaint resolution, so that I can better inform my faculty and inform the work that we do, and it leads to better practices, of course, that are more grounded in legal expertise. We also are student advocates and provide guidance to students around their disability, and that could include anything from professionalism in communication, which is one of my areas that I focus on. It could also include giving the student advice about a particular subspecialty that works well with their disability. I uphold the technical standards and academic rigor of an institution. So believe it or not, people always ask what my role is. That's a question I get often. And I say that I'm the Switzerland of UCSF. I am the go-between, the conduit, if you will, between the students and the faculty. And I make sure that everyone is protected in this process. And I do faculty education and consultation. So I was telling Michelle this morning, about 65% of my job is working with faculty, educating faculty around the law, working with faculty to develop and build processes and policies around different types of the different parts of the medical education. Most recently, we met to tear apart the OSCEs and the CPX and really look at what we were measuring so we could determine what accommodations were appropriate in that setting, and then made policies and processes around that. Okay, so what are the other roles in this process, right? Because you have me, or the SDS, the person, but the students also have particular responsibilities in this process, and my responsibilities are very particular for students. Those are to collect and interpret documentation, conduct intake and history with students. So I do a thorough history with the student because sometimes, as I probably presents here at Mount Sinai, students are really high functioning, and they've been able to kind of mitigate their own disability through compensatory skills. So they'll present in our environment, and for the first time, they're actually struggling. They might have never struggled before in school. So I do an extensive history, collect and interpret the documentation, then determine reasonable accommodations. I educate students about professionalism and around their disability, and I provide access to the programs for the students. So that's how I work with students and how SDS works with students. The way that we work with faculty is to educate the faculty and to protect the faculty. We uphold the faculty's technical standards. We maintain the academic rigor by upholding the technical standards and making appropriate determinations around reasonable accommodations. And then I provide consultation with faculty and staff, and that is a large portion of my job. I get calls daily about working with a particular student in a particular situation or a particular clerkship, and then to avoid conflicts of interest. I become involved as an impartial third party that's there and set up to protect both sides. And doing this and having this role in place really helps to protect all parties and avoid this conflict of interest. One of the areas that I work around a lot is the idea of professionalism. This is certainly a competency that you measure, I'm assuming, as is standard in medical education. I'm a stickler around this because I think that for me, the perspective of an individual with a disability coming to medical school is they go through the process, the accommodations are put in place. If a problem pops up or exists, then we'll reconsult about that and determine whether or not we need to adjust the accommodations or make new provisions. But once the accommodations are determined and that's been communicated to the medical school, okay, from my office, then there should be no more discussion around the disability. Trying to normalize the process includes ensuring that students are then viewed as they are along their peers, as any other student would be. I do a piece with my students before they start, and I've alluded to this, the See the Communication Guide. I have a communication guide that I wrote with a colleague for students, and it basically walks students through the process of communicating as a professional. We have to take a step back and recognize that oftentimes our students are 21 and 22 years old, and they come to us directly out of their undergraduate experience where they are used to being a student. And part of being a student means that it's okay sometimes to not be somewhere, like a small group, or it's okay to send a email that would be similar to a text message that you would send a friend. And they need to really, truly understand the level of communication that they're going to be held to, the amount of professionalism that they're going to be held to. And they need to learn how to communicate around their disability in a way that's professional and respectful and doesn't cross boundaries with their clinical staff or their faculty. Unfortunately, there are times when students will, through their communication, disclose too much or try to elicit empathy around their disability, and that's completely and totally inappropriate. As well, on the other side of that conversation, sometimes faculty, and I think more well-intentioned on the faculty side, will reach out to a student and ask questions that perhaps they should not be asking. Usually it's in an effort to support the student. I've seen faculty rally around their students, and that's amazing. But today I'm going to talk to you a little bit about cautioning you to have deeper to not have deeper conversations around disability with your students, and to let the objective third party do all of that discussion with the student to keep everyone impartial. Because the students are being assessed by the faculty, and so we want to keep everything in this impartial zone when it comes to disability. So some of the things that I talk to students about are their communication and writing, follow-up. So I really stress for students that for example, a clerkship director or a course director is doing a million other things, right? And that it's important, I put the onus on the student to follow up and follow through with regard to testing accommodations, if there's going to be an absence and there is a makeup session that needs to be addressed, that the student take the responsibility for taking the leading role in this and not putting that onus on the faculty member. The idea is, and sometimes I have to step in and smooth this over as well, but the idea is not to put more work on the faculty member as a result of having a student that has to have accommodations. Clarity. I think one of the things that students get lost in, they're uncomfortable talking about their disability, they don't really know how to communicate around disability, and they are so terrified of communicating with faculty, especially in that first year, and they don't want to seem weak. So I work with them on how to professionally approach faculty and how to talk to faculty and how to be very clear in their communication with faculty so that their faculty aren't reading a 3-page history from the student and the request is 1 sentence within that 3-page history. How to get to the point, tell the faculty member what accommodations have been determined, what things need to be instituted, and how they can assist the faculty member in doing that. Specific accommodations. So I work with students around communicating specific accommodations. Just so you know, I also work on the other part with faculty about how to communicate with students as well. So this is definitely a full circle type of thing that I do to support the entire school. Sometimes faculty members will get emails from students that are registered that they're uncomfortable with, and I'll step into that role to liaise with the faculty member on how to respond to the student. And then on confirming. I think confirming is a big deal. It's one thing to hand a faculty member a letter at the beginning of a 8-week clerkship and say, you know, I need this day off for a doctor's appointment, or I need time and a half on my shelf exam. But to go circle back closer to the date of the needed accommodation and to confirm that. So what is the role of the faculty in all of this? Well, your role is do not ask students questions directly about their disability. You can ask them questions, certainly. But so certainly you do ask questions, but we don't want you to ask disability-specific questions to the students. If you have a question about accommodation, what is good practice is for you to then ask the person providing the accommodation or the person in that SDS role, so that the student doesn't feel like they've been put on the spot. Respond to the students in a timely manner. And I think even just to say, I've received your letter of accommodation, and we can have a longer conversation about this, or I'll make sure the accommodations are in place. But just to respond to them, because we do see students have anxiety around communicating about their disability. So once they receive that confirmation from you, they tend to calm down about that. Refer appropriately. And so what I mean by this is, if you have a student that comes to you and discloses, and they're not going to come to you and say, I have a disability. Most likely, they're going to come to you and say, I'm so depressed, or I'm feeling really anxious about this, or I don't know why I'm not finishing this exam. All of these kind of alarms that should go off in your head that say, okay, this student needs to be sent to the appropriate support services. So if you have a learning specialist, that's an excellent place to start, because the learning specialist then can weed out the students that need to go to disability services and identify those based on their clinical experience. But if you have a student mental health well-being or a student counseling center, something of that nature, that's also an appropriate placement. And then those people should be highly educated around what the Disability Services Office can provide. And that's another route for a student to make it to our office. Include a statement in your syllabi. That is important. That sets a tone. It's very welcoming, and it also directs students where to go if they're having difficulty. So instead of coming and having that awkward first conversation with you where they might or might not disclose, that gives them complete direction of where to go, and it avoids those awkward conversations. And it also makes them feel welcome to disclose. Never, ever, let me go back. Follow stated policies and procedures. And I say do this uniformly. One of the things that the Office of Civil Rights will look at when they come in, if you receive a complaint, is they will look at what you've done in the past. So this is the opportunity where your history and your decision-making historically with other students will be used as a guide against the decision-making that you make with this student. So it's really important that you have policies and procedures in place and that you follow them, and finally that you document every step that you've made, every communication that you've made with that student, so that in the event of a complaint, you're able to pull all of that history up and present it. Never say no. If a student happens to come to you and happens to disclose and happens to ask for something, I was in a conference with a faculty member who said, that will never happen. And I was like, please do not ever say that. One of the things that we are charged with is having something called an interactive process. We're mandated to have this. We have to consider every request that comes to us, no matter how far-fetched it may seem, when it first presents. And so I'll take you through a few examples that I've worked with before that may seem preposterous to you on just their face value, but once you get into the situation, you can see how accommodations could be given. So please never say no. You can always defer. Just say, you know, there is someone that is in charge of doing this with students, and I will send you a follow-up email and refer you to them. That follow-up email is very important because a lot of times we get into a he said, she said situation. And I can't speak specifically because I'm in the middle of it now, but I have been in those cases before where a student states that they disclosed to the faculty and the faculty says they never heard anything, but you are all agents of the university. So when a student comes to you and discloses, then the responsibility lies with you to make sure the student is referred to the appropriate agency or representative for the university. So I would encourage all faculty to have some type of statement with a direct email to whoever is in charge to then be able to sit down and, after interacting with that student, send a follow-up email, date, time stamped, documentation, referring them to that person, to that officer for the school to handle their
discipline. Is that considered a breach of privacy?
No, because the student disclosed to you and asked for your advice. So you're just following up via email. And if you think about it, a student that might have an attentional issue, you know, they say something after a test. This is how it normally goes down, right? There's a test, the student is terribly frenetic, the anxiety is building up, they can't finish the test. After the test, they come up to you and they say, I had accommodations in undergrad, I need more time, I can't finish the test, I have anxiety, whatever it may be. And you say to them, as you're trying to collect all of the exams and get back to whatever it is that you have in the afternoon, you say, I will follow up via email with you and direct you to the right place so that you can investigate whether accommodations are appropriate, or, you know, just I'll get back to you with an email is quite appropriate as a response. And then the student has all of the information, but it's also, like I said, documentation that you did your due diligence and referred the student to the appropriate office. Any other questions? No? All right. And then work with us. So I'm lucky in that my faculty know me and are used to me, and they know that I don't make, well, sometimes I'll make just a general statement to say you need to do this. But we've developed a relationship, and so they trust me, and they know that when I tell them to do something, it's to protect them and it's to foster and support the student. But what I've been able to do at UCSF and before at the Cleveland Clinic and at CASE is to go into the clinical setting, go into the clerkships, meet with the directors, meet with the first year and second year directors of the courses, and really and truly understand as much as one can without having an MD. All four of my sisters are doctors, and my mother loves to say, none of you can write a prescription. Thank you very much. So as much as you can to be able to understand the clinical environment. And I precepted before and worked in public health. So I have a little bit more understanding of the clinical realm, but to be able to see what you do on a daily basis and to be able to see what the environment is like really, really helps inform my work. And it leads to really good decision making. And it leads to the faculty being represented and their concerns being represented even when they're not in the room. So OBGYN and surgery are two notoriously difficult clerkships for students that have chronic health issues or mobility issues because of the strength that's involved in those settings. And so going in and having a better understanding of what happens on a daily basis going into the OR, I've rounded with each clerkship. I've been in the OR for those rotations that include an OR element. And it's fascinating to be able to then take that and apply it to not only accommodations, but the development of new technology, which we're working on now. I'm working with cardiothoracic surgery and Google Glass to use captioning, real-time captioning in the OR so that the student has clear vision of the surgical field and can also see the words coming across the Google Glass. I'm also in talks right now with one of our biomedical engineer faculty about building a new stand-up wheelchair, and we'll talk a little bit more about those, but one that can make its way through inaccessible entrances like hospital rooms, which is kind of ironic, right? That it's really difficult to get to maneuver physically into what is essentially a room made for someone who might have difficulty maneuvering physically. So let me go back and talk about the role of the student in all of this, because the student does have some responsibility, and that is to provide timely notification to the school. One of the questions that I often get is, can we put a time limit on this? Can we say, you have to tell us 2 weeks before the clerkship begins, or you have to tell us a month, especially around the OSCEs and the CPX. I finally got faculty, because I paid for it, to just reserve our standardized patient facility for another room so that we would have that in case we needed it. But everyone wants advance notice, and I certainly understand, respect that, and try to enforce that with the students. Unfortunately, the way the law is written, students can disclose at any time. And so we might not have as much lead time on these accommodations as we'd like. And if that happens, OCR is going to come back and say, did you have reasonable means for providing this accommodation? And it's really hard when you have a large endowment to say, if it is at all feasible to make the accommodation happen, that you didn't make the accommodation happen. And so that's something that I caution you to consider when saying no or dragging accommodations out. And one thing that I'm trying to think of an example where it would be an undue burden on the university, and Michelle and I were talking about the lack of access to sign language interpreters. And so if you had exhausted all of your referral basis for a sign language interpreter, and you can prove all of your actions that you weren't able to find one, then perhaps something like going to CART instead, because you could provide CART to the student in the interim while you still continued to work on a sign language interpreter. That might be one example of an accommodation that you could technically absolutely not make because you can't find an individual. One that I would say would be very difficult, and this occurred last year, where we had set up extra time for some students on the OSCE, and we had a student who's notorious for last-minute communication, and had said that they did not want accommodations. And of course, at the 0 hour, and I am talking the night before, said, nope, I've decided I want them. And we were able to squeeze the 2 students into the existing rotation by doing some mathematical algorithm that I can't even begin to understand. But we were up till 2 o'clock in the morning figuring out how to accommodate the student. Myself, the director of the OSCE, I will say none of us were happy about it. So we had that shared sense of being certainly being disappointed in the students' communication and wishing that it had happened sooner, but we made it happen. And we felt collectively like, one, it was in the best interest of the student as well, and I'll talk about the pragmatic part of my job. We also felt like it was the best practice and the most prudent step in order to avoid any type of litigation. So the students' roles also include maintaining boundaries. I spoke to that a little bit earlier, where I talked about students that have a tendency to overshare, are oversharers, students who have a tendency to tell you their life story and why things are so hard for them. That's not appropriate in medical education. That's not appropriate in the profession. And so I make that very clear because, again, sometimes we're dealing with 21 or 22-year-old students who have, in their defense, been positively reinforced for this behavior in their undergraduate situation, where they had faculty who kind of took a parental approach to them and really fostered them through that undergraduate experience. It is the role of the student to work directly with the office that the medical school provides, so the SDS office, and for any changes or updates. So not to come to the faculty member and say, this isn't working, we need to come up with something else, but to go back, and they're instructed to do so, to go back to us as the expert and let us look at the case again. If there's more documentation that we need to consider, then to do that. We may need to converse with clinical faculty. One of the things that the coalition does is it provides an exchange of information for professionals in this field from the best medical schools in the country. So if you think about all of the top schools, they're all represented on this coalition. And I feel empowered, but also very grateful to be able to pick up the phone and call my colleague down at Stanford and say, I need this whatever microscope, this thing that will allow my student to see more clearly. Do you have one that I can borrow? Or to say, look, this is going on and we need a third-party opinion on this. Do you have some time to consult for us? And we all support each other in that. And sometimes 2 or 3 or 4 heads are better than one. And so especially when you're thinking about outside-the-box accommodations, it's better to get a lot of DS workers, disability providers together to think this out and talk it out. To communicate professionally. And like I said in my previous slide, we have a communication guide that we provide for all students. This is not a proprietary thing. We have allowed other medical schools to use it as long as they cite back to the original source. And it's something that it's very student focused, and I will say it breaks down everything very clearly. So it gives example emails, it gives example bad emails, good emails, and why specifically they're bad or good. It also talks about why it's important to communicate professionally, and it talks about how to approach faculty in certain situations. And then the student's other job, last job, is to meet the technical standards. So I have a situation that I'm working with now where a student, in their enthusiasm to share their disability with me and to share how impaired they are, what unfortunately they have essentially done is become a person that's not otherwise qualified. So there's a level of impairment that qualifies for SDS, and then there's a level of impairment that goes beyond that whereby the student is no longer qualified to be a medical student. This is the reason that we have technical standards, right? Everyone can't go to medical school. And unfortunately, and that's where the pragmatic part comes in, unfortunately, everyone will not meet the technical standards, and that's just the way it is, and you need to be able to say no when no is appropriate. And so we also support faculty and admissions people in making that determination, whether the student is capable of meeting the technical standards. And then there are some times, especially around psychiatric disabilities, where students will come in having been able to meet the technical standards, but this also cuts across mobility issues as well, because we have students that get in car accidents, right? I had one at Case that entered and before starting the first year was paralyzed in a car accident. Now he is a pediatric surgical resident, and uses a stand-up wheelchair. So there you go. He was still able to meet our technical standards. However, there are times when things happen and people will need to go another route because they won't be able to meet those. So back to what I was saying about psychiatric disabilities, there are times when students come in with a known psychiatric disorder, which is managed quite well and they're able to do well, and then it might be that they hit third-year clerkships or some other bump in the road that then makes their functioning highly impaired such that they're no longer an appropriate candidate to be a medical student, and they're not meeting the technical standards, or they're not otherwise qualified because their disability is so impaired that they can't meet the requirements, and it would cause a fundamental alteration of our program.
I have a question.
Mm-hmm. Yes.
So in terms of technical standards, it
Right.
seemed that those standards shift significantly at the transition from undergraduate medical education to graduate medical education.
Yes.
Does your office provide counseling to students requiring accommodations regarding what might be a good match
Right.
or a poor match for them?
Yes.
And to their responsibility to notify, are they at all responsible to notify the residency programs that they are applying to?
No, and you cannot ask.
Because we're seeing these referrals now
Yeah.
after the fact.
Yes.
Psychiatric disabilities that were
Right.
not disclosed.
Right. No, they do not have to disclose them.
Two, they start to melt down as their
Right.
hours increase.
Right.
So the first
Right.
is, do you counsel them and advise them?
Right.
And how does that process go?
The answer is yes. I counsel them, I advise them. I also connect them to the human resources contact that works with residents and fellows and postdocs so that she can give them a sense of what they would receive in that graduate medical education experience as an accommodation and what would and would not be appropriate in that at that level of education. So yes, I also counsel them around their disability in a way that you cannot, because it could be considered discriminatory. But I can have a conversation with them about their choice of subspecialty, right? I can talk to them about the need to choose a specialty that works with whatever the challenge or the obstacle is in a way that allows them to be fully functioning in their career. And as far as matching, are you talking about matching to site or matching to the specialty?
If a particular specialty is not well suited to the accommodations, and in fact, perhaps would not be able to make reasonable accommodations,
Right.
would they be advised away from that specialty? Do they have to accept that advice?
Okay.
We're beginning to see referrals on
Right.
the graduate medical education level where in the process of exploring the performance issues that are brought
Right.
to our attention, we then learn that there may be learning disabilities, there may be a psychiatric history, other issues that were not disclosed
Right.
moving forward and present very real problems in terms of
Right. So again, I just want to stress that you can't ask, and they don't have to disclose that to you until they've been accepted and matched with you. But that is an issue, and it is one that I can counsel them on, but I want to be very clear that I can't force that, and I can't disclose any of that counseling to the medical education committee or the dean that writes the letters for matching. What I will say is that sometimes, after the step one, so many of the specialties are weeded out automatically, right? So students that have long-term psychiatric issues, I will say have a pattern of going into certain subspecialties that are more readily able to be accommodated. But those accommodations, when we talk, there's limits to what I can do as well. They don't have all of the, they don't have free reign at the undergraduate medical education level either. What we do around psychiatric disabilities includes release of overnight call, and instead they take a weekend day call so that they can maintain good sleep hygiene. So we do that readily. We try to encourage them to maintain good sleep hygiene and maintain good mental health. So we try to support them around that. And that's across the board in all of the institutions that I've been in. As well, a clerkship placement for a student might be such that if frenetic environments make them more anxious, it might be that we remove the general from the lottery so that they're not sent there, and that I don't want to say, my dean always says, don't say strategic placement. But essentially that's what you're doing, is you're matching the student to an environment where they're going to learn the most and get the most out of the clerkship, and where barriers to their education might be reduced just by the natural setting or knowing that particular clerkship. So we do this behind the scenes thing where we just take out those clerkships. If there's a clerkship that presents a barrier, this is most often geographical actually. When we have a student with a chronic health issue that needs to stay on the bus system so that they can get to the different hospitals, we'll remove any clerkship placements that are not able to be accessed through public transportation or our own shuttle system. So that's a good example. And then everything else is fair game. It's not like the student is, hand-picking or hand-selecting their clerkship. We're just making sure that the inaccessible clerkships are removed. But as far as psychiatric disabilities go, again, we work with the student around that release of overnight call, maintaining good hygiene in all of its forms, so mental health, sleep, and being able to access their practitioners. So oftentimes that involves either leaving clinic by 5 to get to a weekly appointment, and then they come back and work whatever hours or finish their notes or whatever the case may be. And then we work with them around leave. So one of the things that I do behind the scenes that the medical faculty probably recognize, but we might not be having this conversation. In fact, I know we wouldn't be, because it would be a breach of confidence to have the conversation about a specific student. But one of the things that I work with students on are their plan Bs. If everything goes wrong, or you have a psychiatric incident or episode, or you start to see the triggers and you know something's coming, what is our plan B? And I encourage students, and I think, are there any psychiatrists in the room? Okay. You don't look like it. No, just kidding. So one of the things that I encourage, I don't know if you'll agree with me or not, but feel free to either way. One of the things that I strongly encourage my students with long histories of psychiatric illness to do is a psychiatric directive. And I think that really empowers them and helps to include that plan B. Where do I want to go? What happens? Who are the people I call? What medications do I not want? And then we put that on file with their provider in the student health and counseling. I have it on file so that I can access it. If I get a call from a clerkship director saying, I'm starting to see some really odd behavior, the correct way to approach that is for the clerkship director to tell me, and for me to liaison with the provider, and for us to confront the student with, we're seeing some issues, and we want to help you before you're unable to help yourself or make decisions for yourself. The other thing that I will say that we do is we try not to hospitalize our students in our hospital or at our clerkship sites, because it's demoralizing, especially if we're doing a 5150 to put a student in our own hospital and then they have to go back and do a clerkship there. That's really tough. So we usually try to get them home, right, wherever the support system is, and do their hospitalization there. But we work with students around taking some time out, stepping out of a particular clerkship. That's one reason that I'm not a huge fan of longitudinal clerkships for students with psychiatric disabilities, because if something does go wrong and you're in a longitudinal clerkship, you just bought yourself a whole other year. So we really encourage the traditional clerkships where we can, for lack of a better explanation, piecemeal them together when need be. Because some students, like somebody with an eating disorder, may have, an episode that's occurring that can be resolved within an 8-week period and go right back on rotation. It just depends on the severity of the episode and what the illness is and how the student has mitigated it before, and so on and so forth. And so.
I have a question.
Mm-hmm.
I come from the graduate school, so
Okay.
the issue is a little bit different. But what happens if a student has a psychiatric disorder and is in a lab, and then has to be hospitalized and have it, 5-6
Right.
months off? Should the lab be responsible and keep that position for that individual, or
Right.
should the student go back?
That's a great question. So I actually worked on neonatal intensive care unit noise hazards. That was my thesis, and it was on auditory stimulation, and we used animal models. And so the thing we like to say in my office is, the ducks aren't waiting a year, or the rats aren't going to wait around a year. So what happens when you're in the middle of research, especially when it involves, you might be growing something, right? You need somebody in there collecting that data. So in those cases, what we do is we work with the graduate school and the student to say, look, you need to take a step out. In the interest of this stuff moving forward, we need to have someone else do it. And when you come back, we will work to place you similarly, if not in that lab. We try to place them back into the lab so that they can at least have, it's a lot of work to do and then step out for a year and not have your dissertation data. And it's really hard. I will say, I feel, not that I'm not passionate about the medicine part of it, but I do feel really poorly for the PIs, because it's a lot of work, and when someone goes down, there's no one. It's not like we have people we can call in. And you have to know the work, and it's federal money. While we're on the subject of federal money, Let me remind you that the NIH now is giving supplemental grants for individuals with disabilities. So, if you're not on board for altruistic reasons and to embrace the spirit of the law, you might want to be on board for the cash cow that comes with having a student in your lab. And, and also recognize that, a lot of our medical students don't make it when they get to the clinical year. And I'm talking medical students in general, not students with disabilities. I want to be clear on that. Sometimes I used to say it's not about having a disability or it's not about having autism. It's about being a freshman in college, or it's about being a teenage boy, or it's, there's so many other things that it could be about, right? But a lot of students don't make it. And I know that in medical education, we're devoted to these students. We try to give them every support. But when they don't make it, we need to have a really good career advisor to help them go in a different route and not lose all of that knowledge. And a lot of times our students will opt to go into a Ph.D. program. And so I do encourage them to disclose to the PI because they can get supplemental supports, and that is helpful when you need specialized equipment or the student can only work limited hours.
Would that cover also learning disabilities or
Yes.
physical disabilities?
No, all types of disabilities, right. And I actually have a call in to the National Science Foundation because I'm a little disturbed by how they have students disclosing on their application. They're asking if you have a visual impairment, if you have a mobility impairment, and then if you have other. And if you have other, you have to say what category it is, which I think is bordering on discrimination because no one wants to disclose a psychiatric disability or a learning disability because they're afraid that they'll be met with, well, if you have a learning disability, you can't do this work, right? So I actually have a call into them and we'll let you know. I'll let Michelle know what they say about that. But we want to make, I want to encourage students to do this because the federal government wants to hire 20% of the individuals in the workforce. And, that cuts across CDC, NIH, all workforce, 20% with disabilities. You get something called a Schedule A, you get moved up to it's like having the pass at Disney World, which, oh my God, that sounds horrible to me, just going to Disney World. But, you go and you have the super pass where you can cut in the line. That's basically what it is it's giving almost like an affirmative action to individuals with disabilities in the hiring process. So.
As a state school, are you
Fabulous?
have different standings than the private schools?
No. If you receive federal funds, which every medical school receives federal funds, then you are held to the same standards. So yeah.
Two questions
Sure.
that seem to have a lot of room for interpretation. One is, you mentioned the word reasonable, which we see a lot around
Right.
It's fundamental alterations
Right.
to the educational program,
Right.
Which I think a lot of these cases hinge on differences of opinion on that. Can you give an example, not from your own situation, but maybe from the case law where those were two factors that weighed in or that people had very
Yes, actually, I can. And one is in a slide. Can I postpone that till the slide? And then the first question was around
reasonableness and
reasonableness.
and alterations to the educational program.
Right.
Often in these discussions, people say, well, that's going to be too much of a change. I can't do that.
Right.
It just doesn't seem reasonable. And
Right.
those are obviously areas where there's a lot of wiggle room.
So I actually had a consult last night around reasonable, so I'll use that as the example. I had someone call and say, the student is at the 0 hour, there's an exam on Friday, they're getting requests in for accommodations, and I just don't think I can do this. And I said, is anyone else getting accommodations? And they said yes. And the student also wanted a private room. And I said, well, you may not be able to give the student a private room in this turnaround because that's unreasonable to go and find space. I mean, we have a space constraint that is like no other. But if you're giving...
I'll challenge you on that.
Yeah, come to San Francisco, but around the idea of extra time, if someone else is getting it and you have a conference room that has it, it's pretty reasonable to assume that you could put that in place. And if OCR, and that's what would OCR do? If OCR came in, they would say, oh no, you were testing other people, you could have put that student in there. You have the documentation, you have the application, you have availability in your appointment schedule to, work with the student. So even though we have 10 students that have registered this week, it was unreasonable to not extend that extended time accommodation. What was reasonable was to give him the extra time, but it was unreasonable to give him the private room because there was simply no way to do that in this quick turnaround. So that was the decision I made, and I'll talk about the other in that slide. So really quickly, I encourage everyone to have a neutral third party. That's my role. That's the role of Mary. For several reasons. One, to maintain an impartial compliance with the law. Like I said, back to that Switzerland example. To give students a safe and confidential space. Remember that you are very intimidating, especially to first-year students. And so they might not feel safe disclosing in this environment. And there is a theme of, take no prisoners. Like, you're in medical school, work. It's hard work, do it. So having that confidential, safe space to go and consult is really important. To avoid discriminatory or retaliation litigation that stems from you knowing too much information. And I think that's the most important thing for you to understand, is that you don't want to know the specifics. It is in your best interest not to know the specifics. And to have somebody in place that you trust to have that clinical knowledge and to consult with you when necessary, so that you know that your concerns are being met, and when a decision is made, it's a reasonable decision. To maintain confidentiality of the documentation, you should never see that documentation. And to gain a fresh perspective, because we're able to look at things very differently, because we're not siloed into, one view of medicine, and we're able to consult with other people around the country and be involved in some of these new and emerging technologies. So a couple of cases that I want to use as examples, and this is one that was called a Culture of Discrimination in the reply. And this was a student who did not disclose to Disability Services, but was, after dismissal, put in a complaint as an individual with a disability, so based in the ADA. The problem was the school said, well, he wasn't a student that was registered, so we didn't discriminate against him because he wasn't registered, so how could we discriminate? But it turns out the student had gone to their faculty advisor and had disclosed their disability. So remember when I said you are an agent of the university? Take that very seriously. Had gone to their faculty advisor, had disclosed, and the faculty advisor said, look, if I'm going to be honest, you don't want to disclose. People will look at you differently. They will, And I can see how that would be advice that would be given. I counsel students through disclosing and not disclosing all the time, and I have students who choose not to disclose, and that's perfectly okay. But when they come to my office, they've been apprised of all of their rights, and they've been given the option to register, which is very different from you saying to them, probably wouldn't do it in this case. So what wound up happening is that they allowed the suit to go forward because they said he was discriminated against on the basis of having a disability. So this is the one that speaks to your reasonableness and fundamental alteration of the program. So you guys have progress committee meetings where people are moved forward, right? And in those committee meetings, you make decisions, individual decisions about individual students based on individual information, right? Right. So if you've ever given a student a free pass, and by that, it could be anything. It could be allowing them to come back, even though they didn't meet a policy or procedure, paying for them to be tested, whatever you've done, note it, because it's going to be used either for you or against you in litigation. And this was one case where a student struggled through the first 2 years, met with the dean of students, did okay, was able to pass, got into the third year, started failing shelf exams, really struggled, was diagnosed with ADHD, said, look, manage it with medication, you don't need extra time. They refused the extra time. The student failed, they dismissed her, and they said, well, the fact that she was able to perform in the first 2 years is clear evidence that she's not impaired. Let me tell you, that didn't go down very well. And the dean of students had the ability in that promotion committee to say, we'll go back and give her extra time and see how she does and let her persist, but they didn't, they dismissed her. And so they were actually found to be in violation of the ADA. And part of the decision was based on the fact that they had let other students go through.
With extended time.
With extended time, but also through the program with other issues. It could be having a baby, and so you missed a clerkship, or you failed a clerkship and you had this is more often than not, it's you failed a clerkship because you had an emerging psychiatric illness or you had an emerging issue, and you were allowed to go back and retake that clerkship exam once the issue was addressed.
But can a student be asked to leave the program although the school has done everything to meet the disability requirements?
Yes, and that's how we want it. If we're going to dismiss a student, it needs to be with having every accommodation that was reasonable to support them. And I will tell you, going through an OCR complaint, you are in such the hours. It's the hours that the faculty in the med school complain about, because it's taking away from your clinical teaching, it's taking away from your supervision, and we're talking, depositions and hours of paperwork, and it's not something you want to go down. So this slide speaks to, what are you measuring? What is it that you're measuring? And when we went through that OSCE evaluation, the CPX evaluation with my faculty, we really got to the nuts and bolts of what is it that you're measuring in each part of this exam, and that's how we decide whether it's appropriate to give extra time and whether it's reasonable to give extra time. So I'm sure that you see where I'm going with this is in the patient interaction portion of the OSCE exam or the CPX, is it reasonable to give a student extra time? And in most cases, no. But if a student had a prosthetic arm and needed an extra minute to do some type of palpitation or exam or whatever on the patient, would that be reasonable? Yes, you'd probably have a hard time arguing against that. And then we go into, well, if the student had a concussion and needed an extra minute to think, is that reasonable? And so we walk through all of these scenarios. We have these meetings where we literally come up with fake scenarios, or we use OCR guidance, previous cases, to kind of walk through and say what is reasonable and what isn't. Because reasonable, I agree, it's a vague term, right? And it's subjective. Outside the box, this I spoke to a little bit earlier, and we are short on time, so I'm just going to run through this fast. But when my student was paralyzed, everyone said, well, that's it, he can't go to medical school. And then we got them over the hump of, well, he can go to medical school because he can meet the technical standards. And I just said, thank God he's not a nurse, because you break your ankle and you're out in nursing because their technical standards are so specific. But in medicine, we have a little bit more wiggle room. And then it was, well, he can't be a surgeon, so let's figure out how we're just going to get him through those surgery rotations. And then he's like, but that's what I want to do. I want to be a pediatric surgeon. And so it was, everyone met him with different, naysaying, like, no, that's impossible. How will you possibly do that? And, 4 years later, he's a pediatric surgical resident that does not need much assistance whatsoever and uses the stand-up wheelchair. So we have to think outside the box when we're dealing with students with disabilities, because the biggest tool I think really a physician uses is their brain, honestly. And so if you have the intellect and you have the capacity to synergize information and see patients and you have the skill set, something like this should not stop you. Best practices for process. Really quickly, the student submits documentation to our office. We go through it. I call it level 1 and level 2 accommodations. Level 1 are accommodations that I determine without consulting with the School of Medicine. Those are things that have been vetted already by the School of Medicine for me to make that determination. And then level 2 are clinical accommodations. And in most cases, those are pre-vetted as well, because we have a lot of students that are registered, so we have a lot of experiences to draw from. But when something new or novel presents, I don't just make some blanket determination and send out a letter. I liaise with my associate dean from the School of Medicine, who never gets a letter, who does not know who is registered. And when I liaise with her, we don't talk about the student, we talk about the functional impairment, and we talk about the clerkship, and we keep it very neutral, focused on what is the barrier and what are the potentials to remove it. If she is unable, she's an internist, if she's unable to answer those questions, then she puts me in touch with a specialist in the department. And then I work with that person in the same way, but we don't talk about the student. We come up with potential solutions. If we disagree about those solutions, then we authorize a third party to come in, and we usually consult with a specialist in that same field at another campus, and kind of do a tie breaking. And that's really good for documentation for legal decision making anyway.
What is your process or relationship with admissions and technical standards?
I just answer questions. So if they have concerns, and that's only going to happen if a student discloses. And our students sign the technical standards every year saying that they still meet them. So
you don't have any input into the forms that the admissions committee uses to.
I wrote them. Yeah. Myself and legal wrote them so that students are apprised of the technical standards and the needs to meet them and what to do if they need accommodations in order to meet them. Yeah. So, and then finally, we notify the student of the decision, and the student then has the letter and is charged with disclosing that to the people who need to know. And we give them the communication guide as assistance in that. So best practices.
How does that work with those 0-hour requests that you get? Like right before an exam,
Right,
and
well-
you have to gather all the documentation and review it if it's like a new.
Right. Well, if it's true 0 hours, 0 hours is different for everyone, right? That's like my 0 hour is actual 0 hour, but faculty 0 hour could be 2 weeks before an exam if it's an OSCE. So it just really depends. Like certainly I can't, I need to look at the documentation, and in many cases, especially if I'm going to decline something, I investigate, prior cases and use those as guidance and actually speak to them in my rejection. So yeah, I take the time that's necessary. But sometimes I work. I say, I work on weekends. Like if it's something that comes in on a Wednesday, and I can make it happen by a Monday, and our faculty are amazing, but if our faculty member wants it to happen, especially if it's a faculty referral, and they're on board already, I know that's not an argument that I have to make, then I'll work to try to make it happen. Feel free to reach out to me. Please don't view documentation. Those are my things. Please don't view documentation. Don't ever say no. Follow up with an email. If you have questions, consult. Like, these are great questions. And these would be great questions for Mary to be answering and going into the clerkships and talking to folks about what their concerns are, what their experiences are with students. And often when you have an experience that's memorable, it's either really good or really bad, right? And I have found in most cases it's been a really bad experience, and so you're kind of burnt on the idea of having a student with any disability on your rotation. And so knowing that there are lots of students who are really effective and really competent that are out there really helps to kind of calm that anxiety around working with a student that needs accommodations.